onto our next session titled Updates in the Management of Advanced Kidney Cancer. Our speaker is Dr. Daniel George, Professor of Medicine and Surgery, Divisions of Medical Oncology and Urology, the Duke University School of Medicine in Durham, North Carolina. He's also the chair of the KCA Medical Steering Committee. Please see his full bio in the program section of the meeting platform. And be sure to keep asking your question in the question box on the right side of the screen. We'll try also to address some of the questions for Dr. Craig during the, that you actually pose with Dr. George. So we are pleased to have you join today, Dr. George. Welcome to the symposium, and the stage is yours.
Thank you so much, Salva, and thank you everybody for joining this morning, this afternoon here on the virtual KCA Patient Symposium. It's my pleasure to go through some of what I think are the really relevant updates in the management of patients with advanced renal cell carcinoma. These are my disclosures, and I just try to work with everybody. There's a lot of companies in the oncology space now, which is really fantastic. We're going to focus on 3 areas. First, we're going to talk about first-line treatment trials and some of the updates to this data and what that means clinically. We'll then talk about refractory kidney cancer, and in particular, one study that was presented this year called the CONTACT-03 study. And then we'll end with some data on non-clear cell carcinoma and some of the progress that's being made in that space. Okay, so first-line metastatic renal cell carcinoma phase 3 trials. There's been a lot of work in this space over the last really decade, but I think in particular in the last 6 years, we've seen 6 different large phase 3 trials, including collectively 5,000 patients treated in the first line setting. And what we mean by first line are patients that have not received any systemic or drug therapy for their cancer for metastatic disease. And all of these trials involved in immunotherapy, something that's targeting the immune system in combination with another drug, either a second immunotherapy in the case of Checkmate 214, or some of the targeted therapies that target angiogenesis shown in these other trials here. And they've all been compared to one common control, sunitinib or Sutent, which really was the standard of care for a decade or more for patients with metastatic RCC. But based on all of these trials has really been replaced with this new line of therapy. The other thing about these trials is that they're included patients that had different, what we call risk groups. So the most common criteria we use is the IMDC risk group, and this really helps differentiate patients based on their prognosis or how long we think they're going to live. And it's important because we want to make sure we're including the broad spectrum of kidney cancer patients. We're not just focusing on one subset of patients. We're looking at the whole group, from patients we think are going to live for many years to patients that might die within a year of their cancer. And that's all included in these trials, some more than others. We'll go through a little bit of that. But it's important to recognize there's a big spectrum out there, and knowing your risk group and your prognosis is something you absolutely want to go over with your physician. Okay, here's what the data looks like. These are the updates, some of them from this year at ASCO, and others may be published earlier in the year in 2023 or 2022. So relatively recent updates. And these are what we call Kaplan-Meier curves. So if people haven't gone over this before with you, these are population representations. So each curve is one of the treatment arms, either the investigative arm, typically shown in color, and in these cases, all those investigative arms are on the top, and the Sutent or sunitinib control arm on the bottom. And you'll notice on each of these, there's little tiny markings. They're not totally smooth line. There's little graduations here, and each one of those is a patient outcome. So we're looking over hundreds of patients. Those outcomes are collected, and every time a patient meets an outcome, whether it's the overall survival, meaning they passed away, or on the next slide, the progression-free survival, the line will go down a tiny bit, and you see this kind of collection over time. So it's helpful because this is really the sum of all those patient outcomes together. And as a patient, you don't know where you're going to be in this spectrum, even if we have these prognostic indicators. So it's important to recognize, to look at the whole population, because that's the best estimate of how patients are going to do as a whole. And what you see here across the board is that they all separate. They all demonstrate a survival benefit. Some of these survival benefits are happening quite early, meaning the patients destined to die early are living longer. And some of these are staying separate all the way out to 5 years or more, 60 months. And that's suggesting that even the patients who do well and are likely to live for a long period of time and receive subsequent therapies are still deriving a survival benefit to this first line treatment. And what you'll see is, I'm sorry, I heard this background. What you see is on the upper left here, this is the Checkmate 214. This is the combination of ipilimumab and nivolumab, 2 immunotherapies versus Sutent. And here we see the separation, and it persists. And all the way out to 5 years, 60 months, we can see this 10% absolute benefit in survival. And there's a median survival here of like 40 or 55 months or so. At 5 years, it's a 48% survival rate. Now, we can't really compare across studies because there are differences in the patients that are involved in these studies and their prognosis and management and countries and things, but you can look at the general trends, and all of these curves are separating out. And it suggests that whether it's with the ipilimumab, nivolumab, or it's the Checkmate 9ER, the cabozantinib, nivolumab, there's a benefit to this upfront treatment. And these curves stay separate as you go. Now, if you look on the right, we have the keynote studies. These are the Keytruda or the pembrolizumab combinations with, on the top, axitinib or Inlyta, on the bottom, lenvatinib or Lenvima. And these curves are also positive. And it's really showing, again, the same kind of benefit. And I think what's really reassuring is the pattern across all 4 of these studies. Whichever one of these treatments you're on or started with, you're getting a benefit over just starting on a tyrosine kinase inhibitor. And that's now reassuring out to 5 years in some of these studies, 4 years in others. Checkmate 9ER, the shortest follow-up, but still the trend continues. So for me, treating patients, I use this as reassurance that these therapies are really showing a benefit across the population. Now, this is interesting. This is the progression-free survival. This is the time on that first line of treatment until they progress. And what you see is there's a greater progression-free survival benefit with the combinations with a tyrosine kinase inhibitor or targeted therapy and immunotherapy than with the ipilimumab, nivolumab combination in the upper left. But what's also interesting is there's kind of a plateau. After about 2 years, that curve for the ipilimumab, nivolumab kind of flattens out, and there's no more progressors. It's like we've changed the disease. Many of these patients are off treatment and still not progressing out to 5 years. So there's kind of like 2 ends to this strategy. One is to say, well, I want to use the agents that are going to keep me in disease control as long as possible. And that sounds like the tyrosine kinase inhibitors and IO agents. Or I want to use the agent that gives the combination that gives me the best chance of being long-term, no evidence of progression out to 5 years or more, potentially off treatment. And that's probably the ipilimumab, nivolumab combination. So you can kind of rationalize either approach, but they're different. And we're trying to figure out, really who are the best patients for each of these strategies. And, we don't have head-to-head comparisons, and that's the biggest problem. But they're coming. And I'll do the next slide here. Oh, first the safety data, which is important because it's the other end of the spectrum. And these curves I'll show you, or these charts I'll show you the safety. And three of them are in this, what we call a tornado plot. Kind of looks like a tornado spinning around here. You have the investigative arm on the left here, and on the right, you have the standard arm, says sunitinib. And what you see is it kind of looks pretty similar on all three of these. There's, some side effects that are very common and some that are less common. The on the x-axis is the incident rates for each of these side effects listed on the y-axis. And in dark are the high grade, the grade 3 or grade 4 rates. And thankfully, those are lower, but there are some that are higher, and there are some that are higher with a combination. So it's important to recognize that there's just a lot of these toxicities that are in the 20, 30, 40% range. Thankfully, most of the toxicities are less than 10% for high grade, but there are a few, particularly hypertension, in these combinations. And that's a little different than what we see with ipilimumab, nivolumab. Here, the rates, the highest rate was 17% for any toxicity. That was the rash, and diarrhea around 16%. And then the high grade rates were really low. Cumulatively, there's a lot of different high grade rates, and I didn't show all of them. The list goes down, but they're all kind of in that 1 to 3 rate incidence, so pretty low rate. But cumulatively, this is over 20%, and we have about 63% rates of grade 3, of any grade toxicity cumulatively here with these. So there is toxicity with the ipilimumab, nivolumab, but it tends to be less. When it happens, it tends to be pretty severe and pretty durable, sometimes even irreversible. So again, it's a little hard to compare these because they're different that way. The other thing to note is the duration. A lot of the toxicities that are low grade with these combinations tend to last for a long time. They're kind of chronic to the treatments that are given chronically over time. Whereas the ipilimumab, nivolumab combination, we drop the ipilimumab after 3 months, and it's just the nivolumab. And some of these toxicity rates, really kind of go way down or don't come back. So again, just things to know about the regimen that you're on and how to manage and accept that. But it's what kind of creates for us some of the difficulties. Now, I think there's hope in the near future, because now the current clinical trials that are being reported out or ongoing are comparing against a control that's not historical like the sunitinib, but it's immunotherapy-based combinations, typically ipilimumab, nivolumab. So I think in the future, we're going to have some nice comparisons to be able to really judge these toxicities and the effectiveness side by side. But most of these haven't reported out yet. There's some novel combinations or adaptive approaches. One has, and that's the COSMIC 313 study. And this was reported last year at ESMO, and we've seen some updates on it. And it's a combination of 3 drugs, the ipilimumab, nivolumab, and cabozantinib, all 3, versus the nivolumab and ipilimumab with a placebo. So it's really our first kind of head-to-head against this standard. And it's using not just an IO TKI, but a triplet. And then again, the ipilimumab is dropped, and it's just cabo-nivo after 3 months. So what did this study show? Well, the first thing to recognize is that it focused on the higher risk patients. So unlike the other studies that took all comers, we focused on the patients that had just intermediate and poor risk disease. And we did that because we're intensifying the therapy. We're giving all 3 drugs up front. And the rationale for that is, well, these are the patients that might not make it to a second or third line of therapy. We don't want to leave anything on the side. We want to see if they can tolerate and benefit from a triplet versus a doublet. And so you see here, 25% of the patients had really poor risk disease, meaning they had multiple poor prognostic indicators. 75% had at least 1 or 2 poor risk features. That's the intermediate risk group. And then other characteristics are shown here. And this is the curve for it. This is the progression-free survival. So the time on that frontline therapy until disease progression. And it was longer. It was a positive study. The cabo, nivo, ipilimumab combination delayed progression, even in this high-risk population of metastatic kidney cancer, over the ipilimumab, nivolumab combination alone. But what was interesting was two things. One, it wasn't the same in the entire population. We would have thought that up front, this would have benefited the poor risk patients. You can see 213 poor risk patients more, and it didn't. In fact, it looks almost the same between the two curves. But where we saw the greater benefit was in the intermediate risk patients. And that's where the hazard ratio here, 0.68, almost a third longer time to progression was significant. The other, I think, important aspect of this was the side effects, the toxicity. And adding 3 drugs definitely added to the toxicity, and in particular, the liver toxicity, something that we see with a combination of cabozantinib and nivolumab, but it was even more so when we added the ipilimumab up front. And some of these patients, about a quarter of these patients, had grade 3 or grade 4 liver toxicity, which can be very serious. It can reverse, but it does require us to stop all the therapy. And there was, again, sort of high rates of hypertension and some other enzyme changes associated with this. And what we see here is in managing the toxicity in the frontline patients, how many patients were able to receive all 4 doses of ipilimumab was definitely compromised, probably because of that liver function. Only a little over 50% in the Cosmic 313 were able to get all 4 doses. And that's different than what we saw in Checkmate 214 or in the Cosmic 313 from the Ipi-Nivo alone arms. These were pretty similar, around close to 70%. Again, some of the higher risk population here may have struggled as well, so that's why you might see a little difference. But overall, this was a big difference here by adding the cabo. So we lost the ability to give full ipilimumab in some patients. And the number of patients that required steroids, high dose prednisone, or other drugs that really kind of counterbalance all the things we're trying to do with the immunotherapy. It's really given to prevent and treat high risk side effects, but it to some extent can attenuate the effectiveness of the drugs. That was much higher in the Checkmate 313, and it may be why these poor risk patients didn't benefit as much as the intermediate risk patients. So moving on to the second line, our refractory setting, for a while now, we've struggled with the question of whether or not when patients do progress on these frontline therapies, is it better to just keep the immunotherapy going and add different tyrosine kinase inhibitors or other drugs, or should we really be giving up on immunotherapy once they progress on immunotherapy in the first line setting? And it's an open question. We haven't really had data until this study, the Contact 03 study. And this study was reported at ASCO this year with Tony Schwery, and it was looking specifically at patients with advanced metastatic renal cell, clear cell, or non-clear cell. So a broad population of patients, broad risk groups, and patients had to have treated with at least after a prior immune checkpoint inhibitor. That's the ICI. That's one of these drugs like nivolumab or ipilimumab or pembrolizumab. They could have also had the tyrosine kinase inhibitors as well. And again, we had the risk groups, the histology, we stratified by all that. They were treated with either cabozantinib, which is really one of our standards of care tyrosine kinase inhibitors in this refractory setting, probably our most active single agent in this setting, versus atezolizumab and cabozantinib combination. Now, why atezolizumab? Well, this drug is approved in lung cancer and some other cancers, but it's not FDA approved in kidney cancer, so we're not using it in the frontline setting. And so we could use the different ICIs in this frontline setting and still include all those patients. But it's a PD-L1 inhibitor, so it's a little more specific than some of the other checkpoint inhibitors. So, it's unclear if it's as effective in kidney cancer. So those are sort of the pros and cons of using that agent here. And these are baseline characteristics going through. They're really balanced for the most part. Very few patients got adjuvant therapy. Along the course of this study, pembrolizumab Keytruda was approved as a adjuvant following, say, high-risk surgery, stage 3 kidney cancer. but only about 1% of patients actually got that, or only about one patient in each group got that. So that may change this field in the future. Secondly, it was mostly clear cell, but about a quarter or so of patients had non-clear cells. So it's important to recognize that group. And then most of these were good risk patients. There were good, intermediate, and poor risk patients, but there was a little bit of imbalance. A few more patients that were the favorable risk in the cabo arm, but not dramatic. Maybe an 8% difference here, or an 8 absolute rate, higher rate here of the favorable risk group. Okay, so this is the most common prior systemic therapies. Remember, they had to have a checkpoint inhibitor, and about 30% had ipi/nivo upfront as their treatment. And then others got the combinations with a checkpoint inhibitor and a TKI like axitinib or lenvatinib. So about 20% got that, and 30% got the ipi/nivo. The others got a tyrosine kinase inhibitor like sunitinib or pazopanib. Remember, this is an international study, so people from all over the world, some of which don't have access to some of these upfront study agents in combination. And then they may have gotten nivolumab as a second-line agent. And you can see 45% of patients had second-line treatment. So well, 55% just had one line of IO-based therapy. 45% got a first line and a second line. And of those second line, most of them were nivolumab. So this was the endpoint, and it's a negative study. Now, negative is, I always think, is kind of a harsh term. We learned a lot from this study. One of the things we learned is that patients didn't do any worse getting the IO therapy. They actually tolerated it pretty well. We did see some higher rates of toxicity, but for the most part, patients were able to tolerate both drugs. The median progression-free survival was over 10 months, and that's way better than any of our phase 3 historical experiences with these tyrosine kinase inhibitors like cabozantinib, and I'll show you that data in a minute. Third, it didn't seem like these curves separated at all. They were literally right on top of each other all the way through the population. So it doesn't appear like there's a subgroup that may be benefiting or subgroup that's doing worse. They really looked identical, and it really looks like the cabozantinib alone is really driving, most of this, if not all of this outcome. As I mentioned, there were some differences in toxicity. It was a little bit more grade 3, grade 4 toxicity, but about twice the rate of serious treatment-related adverse events. These are the treatment-related adverse events that we're holding drug for. Really bad diarrhea, or using steroids or other things, about 12% versus 24%. And if you look at some of the other factors down here, some of the drug withholds from cabozantinib and other things, there were higher rates of discontinuing cabozantinib in the combo arm, about 10% of patients, versus just about 4% of patients in cabo alone. So the drugs do have an effect, and the side effects do have an effect on each other, and it may have mitigated some of the benefit potentially. Now, if we look historically, I mentioned this earlier, this is better than what cabozantinib initially reported as. Initially, it's studied in 2016, the METEOR study, compared to everolimus, an older drug that we used early days in targeted therapy for kidney cancer. It doubled the time to progression and improved the survival by 5 months. It was a clear winner, but the median time to PSA progression after prior tyrosine kinase inhibitor was 7.4 months. And these patients, for the most part, weren't treated with an immune therapy. So it does appear that the immune therapy in the first or second line setting has a carryover effect. And maybe cabozantinib doesn't have to be given exactly concomitantly, maybe even when it's given sequentially after an immune checkpoint inhibitor, we're getting an additional 30%, 40% benefit in progression-free survival and maybe overall survival. So it really kind of sheds light on what our expectations are now in the second-line therapy, and they're better than they were just a few years ago, using really the same therapy. So I think the takeaway is that atezolizumab plus cabo didn't really add anything. I don't know that that completely closes the door on using IO therapy in the refractory setting. I think we do need some more studies. There may be differences in the IO agent. There may be differences, but with what we're combining it with. And there's an ongoing study right now called TiVo-Nivo 2 or TI-Nivo 2, and that is looking at the combination of nivolumab and tivozanib. Tivozanib is a newer tyrosine kinase inhibitor, a little more selective than cabozantinib, maybe a little bit better tolerated, and it's approved in the refractory setting as a single agent after both an IO agent and a tyrosine kinase inhibitor, so standard of care, and we're comparing that to nivolumab in this setting. So we'll see if there's a real difference with a more of a proven checkpoint inhibitor in the refractory setting. So lastly, I'll just end with the papillary renal cell carcinoma story, because we don't talk a lot about it. There's only 15% of kidney cancers, but if you have papillary renal cell carcinoma, that's what's important. Whether it's the common dominant type or not, it's what matters to you. And the data isn't necessarily exactly the same when we look at our treatments for these papillary or non-clear cell types compared to clear cell. So it's important to recognize we need studies that are specific to these subtypes of kidney cancer. And thankfully, there are some. This was a cooperative group, a NCI-sponsored study from the SWOG cooperative group, Southwest Oncology Group, that looked at a series of tyrosine kinase inhibitors. You can see them listed on the top here that blocked, as in the case of sunitinib, VEGF, cabozantinib, VEGF, and MET. And MET is another target of these targeted therapies that may have more relevance in papillary renal cell carcinoma. Crizotinib and savolitinib both block MET but don't block VEGF. And what we found was the VEGF inhibition matters. Sunitinib and cabozantinib had the best outcomes. And of those, cabozantinib had the best outcome. So maybe blocking both targets really matters. Maybe blocking one target is effective, but maybe it needs a second partner. So, so we have a couple of follow-up studies now. This is Lenvatinib-pembro, and this was looked in non-clear cell renal cell carcinoma in both the first and second line setting. And what we see here is really fantastic results for this combination. And it really adds belief that maybe IO therapy can add to non-clear cell carcinomas as well as it does in clear cell carcinomas. And we just haven't had a lot of data. But this was a large single-arm study and a number of different histologies. And one in here, right here, is the papillary, the second one, bar here. And this is the overall progression-free survival. And it was 18 months for this papillary group of patients. So really durable effects of using lenvatinib and pembrolizumab in combination. These are all the individual patient responses and degrees, some of them near complete responses or deep responses. Some of the toxicity shown here. And in the interest of time, because I know I'm running close, I want to save time for questions. We have the PAPMET 2 study that's going to be looking now at building off of those positive results with cabozantinib and adding atezolizumab in this setting, cabozantinib and atezolizumab in combination in these untreated non-clear cell papillary type renal cell carcinoma. So specific to papillary in patients that have not had any prior therapy, randomized to either cabozantinib or cabozantinib plus a immune checkpoint inhibitor. And then finally, this study, the SYMETA study, which is looking at one of the other tyrosine kinase inhibitors that block MET, savolitinib, in combination with another checkpoint inhibitor that's approved in bladder cancer and some other cancers called durvalumab. And they'll be looking at durvalumab alone in these papillary renal cell carcinomas, as well as durvalumab plus savolitinib, and comparing it again to one of the historical drugs we've used, sunitinib. So you've got sort of 3-arm study here, and we'll see if there's an additional effect of a checkpoint inhibitor or the combination of a checkpoint inhibitor and a MET inhibitor over sunitinib. So I think in summary, immune-based first-line treatments really are now the standard of care for patients with metastatic renal cell carcinoma. And I think the outlook is really promising for long-term disease control rates out to, up to 30% of patients with long-term disease control rates. And even for the overall population, we've extended survival dramatically now for these patients and improved the outlook for even our intermediate and poor risk patients. I think it remains to be seen how to build on these regimens still, but in the refractory setting, the single agent tyrosine kinase inhibitor is still the standard of care. Cabozantinib alone has been hard to beat. And I think we need to understand more about this population and what else we're missing to add to drugs like cabozantinib. And then finally, I think in non-clear cell types, in particular papillary, we're starting to see more and more specific trials. We're starting to see better and better outcomes. I think there's real genuine hope that we're going to figure out some approaches that may be a little bit different for papillary and non-clear cell from clear cell carcinoma. If nothing else, at least we can feel comfortable that some of the results we're seeing in clear cell carcinoma do overall, reach into the papillary and non-clear cell. That some of these combinations like lenvatinib and pembrolizumab can show broad activity across a number of different histologies. So I'll stop there, and I think that's my last slide. Yes, it is. Okay. Happy to stop there, Salvo, and take any questions. I can't hear you. I don't know if others can hear you.
Sorry. Thank you, Dr. George.
Sure.
I was on mute. This was extremely, educational. We learned so much. We know that now we need to look, when we saw those graphs, we need to look at the gap. The more gap we see between those curves, the more effective is that treatment. And then when we see that water flow plot, the longer the lines, that means, the better the response. So we need to see those going down to zero. So that means that the tumor reduction is almost complete. So thank you so much for showing. It's so important to see so many studies and so many options available for patients being developed. That brings me to the first question. We have only a few minutes, so please be quick. I will try to, give you a few hints. We saw a lot of, triplets. So, single, double, and triple combination. What about adverse events, but also quality of life for patients? How do you distinguish between, those two when we decide for a treatment?
Yeah, this is really the personalized approach to all this data. How do we interpret it and then apply it to individual patients? And it's really that risk tolerance. How much risk are we willing to take? And a lot of it depends on how aggressive the cancer is, how many, if we're having symptoms and other real imminent concerns, versus a disease that's slow growing, that's a low volume disease where we have time to try different approaches and build. I like that. I like adaptive approaches where we start with something and then depending on the results we adapt. We either intensify if it's tolerated but it's not working enough, or we de-intensify. We take some things away if we're getting a great response but a lot of toxicity. So this data is really important to recognize. It's for approvals, but in practice, we have a lot more flexibility in how we manage patients, and we can tailor this dynamically over time.
There's a question about the risk of Guillain-Barré as a side effect for the Opdivo-Yervoy combo. Can you comment on that?
I'm sorry, can you say that again?
Guillain-Barré. This is the first question from Lisa.
I'm sorry. Yeah, it's French, not Italian, Saba. Guillain-Barré. Guillain-Barré. Yes. So, sorry, just teasing. No, this is a really important, thankfully very rare, but serious complication. Immunotherapies can affect any part of our body. And Guillain-Barré is a neurologic complication. It's a complication where it's almost as if we have severed the spinal cord, where we lose function on the spinal cord. There's inflammation that can literally block the blood supply and kill very quickly the spinal cord, so that patients become paraplegic. And it can be devastating We use steroids very quickly. It's very, very important to recognize those neurologic symptoms early and use steroids quickly to try to reverse that. There's not as much a role for surgery because it's immune based. It's not a physical cause. And it happens independently of immunotherapy as almost like an autoimmune reaction in the body. And a lot of the complications that patients experience with immunotherapy are really very similar to autoimmune conditions. And and it's important. We will learn more about our autoimmune conditions from these drug-induced complications. But Guillain-Barré is one that it can be irreversible and very devastating. Certainly something to be on the lookout for. Any kind of numbness, weakness in the lower extremities, immediately seek medical attention.
One very last one, quick one. What is there any gold standard second line treatment for metastatic RCC in the bones that is progressing while on Opdivo?
It's a really important point. Bone complications are particularly worrisome because kidney cancer tends to be lytic, tends to eat at the bone, causes a lot more what we call skeletal events, pain, fractures, nerve compressions, and things like this. So in the Alliance Cooperative Group, we have a study going on with a bone-targeted agent called radium-223 in combination with cabozantinib. Cabozantinib, as I mentioned, one of the standard of care single-agent tyrosine kinase inhibitors for those refractory patients. And there's some data to suggest that it could be even more active in bone and liver lesions because that's where there's a higher expression of the MET protein. So it's a study to look at a bone-targeted agent that releases radiation, an alpha particle radiation, in wherever there's bone scan activity. So we're looking for additional help there. What I would suggest outside of the clinical trial like that